with Dr. Tammy Bradshaw-Scott, a program dedicated to addressing current issues and offering solutions and hope for each new day. Dr. Tammy is a registered psychologist and licensed marriage and family therapist with degrees in clinical psychology. And now, here is your host for A New Day, Dr. Tammy.
Welcome, studio audience, and those of you viewing from home. Many of us have witnessed in recent years, by the way of news media, famous and well-accomplished folks who have tragically died from accidental overdoses to prescription medications. And many of you joining us today may be battling with, or you may know someone who is struggling with the abuse of addiction to prescription drugs. Today, we will be discussing the danger of addictions, and we'll be focusing specifically on the painkiller epidemic in America. This epidemic has been ballooning in recent years. For instance, according to the National Institute on Drug Abuse, in 2012, an estimated 2.1 million people in the United States were suffering from substance use disorders related to prescription opioid painkillers. And an estimated 467,000 were addicted to heroin. Also, the number of unintentional overdose deaths from prescription pain relievers has soared in the US. To help us understand how so many individuals are addicted and abusing painkillers, we have with us today two physicians. Each have expertise and experience treating patients with chronic pain and patients who have addictions to painkillers and other substances. Our first guest is Dr. Sana Lagans, a family practice physician who has worked in local community clinics serving underserved patient populations. She sees patients who have many medical complexities, including chronic pain. Our second guest, Dr. Ricardo White, is the medical director of a local chemical dependency unit and has extensive training and experience working with folks with addictions. Please welcome to our program Dr. Sana Lagans and Dr. Ricardo White. So much for being here today. This is a very important topic.
Thank you.
And we have a lot that we want to discuss and to squeeze in during this time. But, I'd like to start with you, Dr. Lagans, if I may, and just ask you to tell us a little bit about what you do as a physician.
Okay. I am a family practice physician, and I work in San Bernardino at a community health center. And I see patients from children, babies, all the way up to geriatrics, 100 or actually in their 90s, whatever age comes to me. That's what I see on the outpatient only basis.
And what are some of the issues, per se, medical issues that you see?
Diabetes, high blood pressure, asthma, common cold, cough, everything from that to some of the complexities that come from diabetes and the long-term effects, kidney problems, things like this. Chronic pain syndrome is also a real big diagnosis.
Okay. And do you see folks who are, on different pain medications? Or?
Oh, yes.
Yes.
There's patients that come to me who are taking some of the strongest medications out there, oxycodone, morphine. There's one that's real popular now, Norco, tramadol, Soma, which is a muscle relaxant.
Okay.
Lots of different medications.
Okay, that's a lot. How about you, Dr. White? Can you tell us a little bit about what you do and your patients you see?
Sure, Tammy. So I'm the medical director of a local chemical dependency unit, which also has attached to it a partial hospitalization program. So we both detox patients, so they come in medically dependent on substances, and we transition them off of that through a process called detoxification. But then we also want to transition them from the behavior of being addicted to the substance to being substance-free. And so it's in our partial program that we do that. I probably see about 1,000 patient visits annually.
Oh my, that's a lot. And of those, Dr. White, how many would you say you see that have painkillers that they're on to deal with their chronic pain?
I would loosely estimate that at about 30% of the population that we see.
About 30% of your population.
Correct.
And Dr. Lagans, what would you say percentage-wise in your population?
For the adults, I would say in the last 3 to 5 years, we've seen more and more patients with chronic pain syndrome, in addition to diabetes, high blood pressure, asthma, et cetera, depression. On any given day, anywhere from, I would say, 30% up to sometimes 75% in any one given day. So it's hard to know because from day to day, some days it's like almost everyone I see, and in other days I might not see as many.
Right.
But it certainly has ballooned in the last 3 to 5 years, this diagnosis of chronic pain syndrome, which is almost like a catch-all term to include people with fibromyalgia. More and more we're seeing fibromyalgia as the culprit, osteoarthritis. It might be one little joint that is just there for life. And so we call that chronic pain syndrome. So these are examples of what we see.
Well, like in the intro when I started this morning, we were talking about the epidemic and how we've seen this become such an issue in the U.S. and deaths related, to the overuse and using many different medications at the same time. Sometimes folks, don't realize what they're doing and using, and will even use alcohol in addition to that. Let me first ask you, Dr. Lagans, and then I'll come to you, Dr. White, on what is it that you try to do with your patients to help them so that does not happen to them? Because it's no surprise what we've seen in the media and these lives lost with the over-prescribing of these medications.
It's a very scary epidemic. People just don't realize it's not so much the medication in and of itself, although that causes what we call respiratory depression, meaning that it's harder for the person to breathe. And sometimes the breathing can go down and down and down until someone dies. And that's how people die from an overdose of opioid medications. When we say opioids, we're talking about Norco, also known as, or used to be called Vicodin, a different medication, 2 different medications, but Norco is the one that the insurance pays for now. That's probably the most common one that's easier to get. Morphine is also opioids, oxycodone, Percocet. These are all examples of, also Tylenol with codeine. These are all examples of opioids. It's the combination of this medicine with a muscle relaxant. Even with common medications that you can buy out at the store, Benadryl, for instance, NyQuil, anything that causes sedation or sleepiness in combination with Norco, even within a 4-hour period, within 4 hours of taking one or the other medication, sometimes even longer, depending on a person's age and other their kidney status and other, medical problems.
Many factors that most people would not
don't think about.
Average person wouldn't know.
Right. That these combinations is what can cause someone to die.
So with all that said, what do you do as a physician to help them?
Educate and tell them over and over, remind them and tell them, okay, what we're doing is we are methodically and systematically taking every patient on this medicine off. And we're replacing it with other medications and other ways to control pain.
Fantastic. Dr. White,
Yes, ma'am.
what do you do for your patients as we look at the dangers of some of these medications and interacting and what the general population doesn't understand?
Well, part of the major issue that's happened is when patients are left on these meds for too long. So, of course, the literature supports the acute management of acute pain with opiates, so on and so forth. But it's when it's a year later, 2 years later, after that same surgery, and these patients are still on the same level of medication or even more, that's when there's really a problem. So it's a matter of looking at situations like that, tapering them off where appropriately, partnering with other members of the healthcare team so that people can get the care that they need. What this opiate epidemic is doing to the medical community is forcing us to not operate in silos. But we have to reach out to one another. We have to strategize together so that we can address the pressures, both the pressure to prescribe, because we are obligated to make sure the patient's needs are addressed, but then get them off of it when those medications then become a problem.
I mean, there was a time when I had a back injury and I was in horrible pain, you know, and so I understand that kind of pain that just makes you want to come out of your skin. So the pain is real, but we want to get to how do we then help them. But what does your program specifically do as you have folks come in and detox, as you say, and then what do you do in your program? What is the approach in your program?
So initially, of course, they're dependent on the substance, the opiate. And so we'll use a medication very often called Suboxone, which is a synthetic opiate. And we take a look at how much of that they need, and then we, in a matter of days, actually taper them off of the Suboxone. So we manage their withdrawal so that the experience of getting off of the opiates is very humane. A lot of patients are very shocked at how humane the experience is. But after that, you have still cultivated habits that now you need to have rehabilitated. And so the real way to maximize effectiveness is to approach the problem from many different angles. And so we actually have pain groups where we teach them ways of, okay, this is how you should lift. These are the things you should avoid. We help them understand the difference between physical pain and psychogenic pain. Even though it's psychogenic, that doesn't take away the genuineness of it. And so we help them understand how to rate their pain.
Oh, that is wonderful. And so your pain groups, you actually educate them on the way to do life and live life without...
Correct. And one other thing that's fantastic news, one of the things that long-term exposure to opiates does is it reduces how well a person can tolerate pain. And so one of the wonderful things we experience so often with our patients is after they've been off the opiates for a while, their pain level goes down. Their pain level goes down. So it's really refreshing to observe that.
I have actually read that in research, looking at how as you mentioned a moment ago, both of you, the chronic use, that's the problem, is the chronicity of it. And that very recent research came out showing that the development of depression with long-term use of these opioids. What have you seen that?
Well, part of the problem is what long-term opiates will do is it will often disconnect the person from their life. You know, so here it is, you know, you have family members that want to be around you, but because you're under the influence of the opiates, you're not really fully present. And before long, you start experiencing isolation, and of course, that can, of course, depress the mood. And so part of the advantage to eventually getting off these meds is you can actually re-engage your life. Even if the pain has not gone away totally, it's reduced, it's more manageable, and you can re-engage your loved ones.
That is something. So how long would you say someone would be in your program? So a patient comes in, they have this dependence or addiction to the medications. What does that look like in a time frame?
So the magic number you hear for detox is 5 to 7 days, but of course treatment is custom tailored. So we don't like to say it's definitely going to be this or that, but you hear 5 to 7 days for detox. But then to help teach you those behaviors, that's really where the rubber meets the road. That takes more now than 20 to 30 days to help a person really start to ingrain those behaviors.
Not anything unlike alcohol, addiction to alcohol or any other substance
Correct.
in the behaviors?
Correct. I mean, there's a lot of similarities in how much time you need to start helping a person begin their journey with recovery.
Okay. And so they would be in your program inpatient and then they step outpatient and attend groups?
Sure. So it used to be that payers would have their patients stay inpatient throughout the whole process, 30 days, 90 days.
Insurance companies?
Yeah, insurance
Yes.
companies. Thank you for that.
We know them as
Tammy.
payers.
Yes. But now there is such of a pressure, to get them out. And so detox typically occurs inpatient. But then as far as rehab, some patients will either pay cash and stay in patient rehab, and then a few other of the insurance companies will actually pay for them to stay inpatient, very few. So a majority will actually receive their rehabilitation in an outpatient, setting. So they'll be going home or staying at a sober living and then coming into the program for their rehabilitation treatment.
Right. Now I want to touch on this because it's very relevant, and as a therapist and seeing many different patients and clients, trying to refer folks that I knew needed this treatment that is offered cannot receive that because they didn't have insurance. So they have Medi-Cal or IHP. And I've had to roll up my sleeves and do a lot of investigative work to try to find programs that would take these folks who need this treatment. Dr. Lagans, since you work with the very underserved population, you see this all the time, and in your community clinics.
We are challenged.
Yes.
There's just not enough programs. There's the pathway to get them treated. First of all, it has to start with the person realizing that they actually have a problem. And right now, that's the majority of my case. That's the major problem for me, is that people don't even understand that they're actually, they're not coming to grips that there's actually a dependency or a chemical or substance dependency.
Is that because it's a prescription versus like quote unquote a street drug?
Yes,
Okay.
and so psychologically the person is like, well, my doctor's giving me this medicine and
Sure.
I've been on this medicine for years, nothing else works, and I'm in pain. And yes, they are in pain. And we don't minimize that at all. We also know that there is depression, and depression causes pain and perpetuates insomnia, which perpetuates the whole vicious cycle. And now that we know this research about the opioids causing depression, it all makes sense. It is streaming into this vicious cycle. And so it really has to do with educating our patients. But what we're doing is we are detoxing our patients slowly ourselves. Hopefully, they are not getting the medications from outside sources, i.e. other family members, friends, or buying it off the street. We know that is a big problem.
Yes.
And so it is a work in process, and we are collaborating, and we're looking into being able to write prescriptions for Suboxone ourselves and having our own little detox program. Because it's just in high demand right now and short supply.
So what do folks do, you and the other folks do at your clinics to help? Because primarily they have coverage like Medi-Cal, IHP, that a lot of these programs don't accept that coverage. So what do you do for these folks?
We have a wonderful behavioral health team. Thank you that you worked with us on that, and so we are kind of corralling our patients in, really having pain support groups. We're sending them to physical therapy. We're talking to them over and over about heat therapy and massage and other ways to manage their pain. We're getting in those that are depressed, and there's a lot of people with severe depression, moderate to severe depression. We're getting them one-on-one ongoing therapy, and we're just balancing. It's a balancing act. We're case by case, and we're just working with them ourselves at this point.
And you all have pain group?
We do. We have pain support groups. We also have general support groups for just general life issues as well. Both of those, when people take advantage of them, they do say it helps. It really helps.
Yes.
And we need that. It's just
Yes.
that depressed people, sometimes they don't want to come out their house.
Right.
And so that's a little bit of an issue as well.
So helping them with that component
Yes.
and addressing that with the therapist and working on that to get them to a point where they would want to address
their pain and come around other people. When they do come out, they feel good, they feel better, they're glad that they did. So we're finding success. One of the things that we're doing, we're trying with people all kind of different things to distract them from the pain is coloring, art therapy, you know, getting them to color, and this also is helping people to get off cigarettes as well. So you know, we're just trying different things.
Okay. Let me ask you both about the family component here. And as you mentioned a moment ago, Dr. Lagans, the individual may be in denial because, oh, well, this is a prescription. I'm not buying this from off the street somewhere, or maybe they are.
Right.
But if it's being prescribed, they're able to get it that way from their pharmacy, it's okay.
Right.
Right? It's, but we know that, as you've just said, you know, the fallout. So what can we do with the families, you know, and interact with those families and help those families and support them? Because I know that we have a lot of viewers today who are watching and they're thinking, oh my goodness, my sister, my brother, my uncle, what, you know. So what would you say?
So families need to become aware of the high dollar value of their opiates. So you get grandma who is prescribed something for her knee surgery. She uses it for a week or two and then just puts it in the medicine cabinet. And it's the community medicine cabinet, not realizing that if she has a party or she has a gathering, that's high dollar value. So that people need to be more protective of their opiates. They need to understand the natural history that some people experience with opiates. So they might start off with Norco or prescription opiates, but in time start to get it maybe from illegal sources. But it's so expensive, they naturally just transition over to heroin. And so it's really important that the meds be treated with the respect that they deserve.
And that's what I really would like the viewers to understand and folks to understand is that you said it a moment ago that, you know, they may start on, you know, the Norcos or the, you know, these opioids, but can very easily transition right into the heroin because it has that effect. So briefly, how do you, what do you say to the families?
Absolutely. There is hope. There is hope. What makes life actually enjoyable is exactly what it is that we try to re-engage the patient with, okay? So there's spiritual interactions. These are things to start re-engaging. The family interactions. Well, I was going to say shut off the television, but not this program. Watch this program, right? Right? But re-engage. Re-engage, talk, family dinners. You know there's studies documenting that the more you're engaging in family dinners, there's less risk of things like, for example, substance use. I mean, the data is actually becoming more and more available. Also, you know, a lot of people go around and they'll say, I'm depressed, but the way our brains were designed, they were designed for us to get a hit of dopamine when we're engaging in life-sustaining activities. So a lot of times it's not just that you're depressed, but you're not doing anything. You're not challenging yourself. You're not making a contribution. And so the brain's working fine, but you're just not pushing yourself.
So that's the family piece, and encouraging the family to come together is so critical.
And being purposeful and you know, pursuing a purpose.
Absolutely. Dr. Lagans, what do you say to the families to help their loved ones?
Wow, just knowing that, like he said, that these medications, protect the medications. Do not share your medications. If you love your family, you do want them to get their pain addressed, take them to the doctor. Let them get their own medication or treatment for what's bothering them, ailing them. But don't share your medications because sometimes we're hurting for someone. You see them hurting, you're like, well, this helps me, so take a little of this. So that you won't have pain, but don't share because you don't know what it's going to do in their body. You don't know what they have already consumed and what's already in their body. and you don't know what habit you might start in that person. It could be actually deadly. And realizing the combinations of the medications that a loved one is taking may be deadly as well. So just sometimes we feel like if we just take a pill, or if we give this person a pill or give this person some cough medicine, be aware of the cough medicine. It has codeine a lot of times in it, and just be careful with these combinations, being aware and just saying, okay, this is dangerous for you. Let's take this away. Don't be afraid to talk to the loved one's doctor if you're concerned, if you see them too drowsy on the medicines, or just not acting right, or just depressed. Go with them to their doctor and talk to their doctor about it. And even if you have to talk separately with their doctor, reach out on behalf of your loved one.
Thank you both very much. I really appreciate your expertise and everything that you give.
Thank you.
This is so helpful for us to know. I hope this information has been helpful and enlightening for you today. I realize it is very difficult to hear the number of individuals who are suffering from prescription drug addiction, especially if that someone is you. But there is hope. Just as my guests here have said, there is hope. You do not have to suffer alone, and you do not have to continue down that spiral of addiction. As a therapist, I have seen many, many patients and clients receive treatment for their addictions and actually enter into recovery and get their lives back. We want this for you, so please contact the resources on your screen and get help for yourself or your loved one today. I want to thank my guests today, Dr. Lagans and Dr. White, for their expertise and their professional experience in sharing that with us today in order to help you viewers. And I also want to thank all of you. Many thanks to you for joining us here today on A New Day.
This viewer-supported program is made possible by viewers like you. Your support is invaluable and appreciated. To send a gift or for more information, please contact Dr. Tammy at the address on your screen. And thank you for joining us for A New Day.